Welcome to the deep dive.
But
Ready to explore something pretty fascinating?
always ready to dive in.
Excellent. Today, we're going deep into the world of mechanical ventilation.
Sounds complex.
It can be, but we've got an awesome guide. It's a Critical Care 2 course document. Think of it like peeking into actual medical training.
Oh, wow, yeah. Like getting a sneak peek behind the curtain.
Exactly. By the end, you'll grasp how it works, when it's used, and all those crucial things to consider.
A crash course in mechanical ventilation, basically. I like it.
Totally. So let's kick things off with the fundamentals. Why is ventilation so, well, vital in the first place?
In the simplest terms, mechanical ventilation is like a helping hand. It helps people breathe when their own bodies struggle to do it effectively.
Okay, so it's like a backup system for our lungs. Makes sense.
Exactly. Think about situations like apnea, where breathing just stops completely.
Oh, wow, yeah.
Or respiratory failure, where the lungs can't deliver enough oxygen or remove enough carbon dioxide.
That's where things get really serious.
It is.
And speaking of respiratory failure, our source material dives into two types, type I and type 2.
Ah, yes, those are key distinctions.
What's the difference and why is it so important to understand that?
Well, they have distinct root causes, and knowing the difference is crucial for choosing the right treatment approach.
I see.
Type I, it's all about hypoxemia,
Hypoxemia.
low blood oxygen levels, basically.
Gotcha.
Imagine this. Those little air sacs in your lungs, the ones that do the oxygen exchange, what if they're filled with fluid, like in pneumonia?
Oh, so the oxygen can't get through properly.
Exactly. That's a classic example of type I respiratory failure. It messes up the whole ventilation and blood flow balance.
So in essence, the lungs aren't getting enough oxygen into the bloodstream. But the source material also mentions something called a shunt. That can cause hypoxemia too, right?
That's right. A shunt happens when blood kind of sneaks past the lungs without getting properly oxygenated.
Sneaks past.
Yeah, think of it like a detour on a highway that diverts traffic away from a major city.
Interesting analogy.
Right, so conditions like some congenital heart defects, they can cause this. Hypoxemia can happen even if the lungs themselves are doing okay.
Oh, wow. So it's like a plumbing problem in the circulatory system. Okay, so what about type 2 respiratory failure? How does that differ from type 1?
Type 2 is all about hypercapnia, high levels of carbon dioxide in the blood.
Hmm,
This time, the lungs struggle to get rid of CO2.
I see.
Think about COPD, where the airways are narrowed and airflow is restricted.
Ah,
Or even drug overdose. It can suppress the respiratory drive. The brain basically forgets to tell the body to breathe.
wow. I never realized drug overdose could affect breathing that severely. So with type 2, the lungs have trouble expelling that waste product, carbon dioxide. Makes sense. Our source material mentions some surprising causes too, like defective anesthesia machines.
Right. It doesn't happen often, thankfully, but it really emphasizes how crucial vigilance is in healthcare. If an anesthesia machine isn't working properly and messes up the gas mixture, it can lead to a carbon dioxide buildup. A stark reminder that even the most advanced tech can have those unforeseen hiccups.
Absolutely. A sobering thought for sure. Okay, we've got a good handle on those different types of respiratory failure. So how does mechanical ventilation actually step in to support breathing when things go wrong?
The most common approach is something called positive pressure ventilation. We basically push air into the lungs, kind of like inflating a balloon. And to make this work, we need to establish a sealed airway, usually through a procedure called intubation.
Oh,
That's where a tube is inserted either through the mouth or nose and down into the trachea.
So it's different from how we normally breathe.
You got it. We usually create a negative pressure in our chest by contracting our diaphragm, which pulls air into our lungs.
Right.
Positive pressure ventilation, it flips that natural process around. It's super effective for supporting breathing, but it does come with potential risks and complications.
Right. It's like a trade-off in a way.
Exactly.
So there are times when mechanical ventilation is absolutely necessary, even life-saving, but are there ever situations where it's just not the right call?
Absolutely. We always have to consider a patient's wishes, first and foremost. That includes things like DNR, do not resuscitate, or DNI, do not intubate orders.
Gotcha. Those are important.
And there might be certain medical conditions where the risks of intubation outweigh the benefits.
Makes sense.
In those cases, we might opt for alternative approaches like non-invasive ventilation, which can support breathing without that whole intubation step.
Non-invasive ventilation sounds a bit less, well, intense. Can you break down how that works?
Sure, it's all about delivering pressurized air through a mask that fits over the nose or mouth.
Okay, I've seen those.
Right. It's a gentler method that can help patients with milder forms of respiratory failure avoid the potential complications of intubation.
Less invasive, less risky.
Exactly. It can be really helpful for patients with conditions like COPD, where they might need long-term ventilation support. It's a way to give the lungs a little boost without going for a full-on invasive procedure.
I like that, giving the lungs a little extra support. Okay, let's say a patient does need mechanical ventilation. What happens next?
Well, once they're intubated and hooked up to the ventilator, we have to pick the right ventilator mode. It's kind of like choosing the right setting on your oven. Depends on what you're trying to bake.
So the mode dictates how the ventilator delivers those breaths.
You got it.
Interesting. So what are some common ventilator modes and how do they differ?
Well, there's one called assist control, often shortened to AC. It's one of the most common modes.
I see.
In AC mode, the ventilator delivers a set volume of air or a specific pressure with every breath. It does this regardless of the patient's own efforts, like the ventilator is doing all the heavy lifting, so to speak.
So what if the patient tries to breathe on their own while they're in AC mode?
Well, the ventilator is pretty smart. It can sense those efforts and actually syncs its breath with the patient's attempts. Basically provides assistance with each breath, make sure a consistent volume or pressure is delivered. It's super supportive.
Wow, the tech is pretty amazing. So AC mode is often used when patients are really critical.
Exactly. Especially when they can't breathe well on their own. Are there other modes that give the patient more of an active role in breathing?
That's what I was wondering.
Definitely. Another common one is SIMV. That's synchronized intermittent mandatory ventilation.
Yes, IMV. Okay, got it.
With SIMV, the ventilator delivers a set number of breaths per minute at a preset volume or pressure. But here's the key. It lets the patient take spontaneous breaths between those mandatory ones.
Oh, that makes sense. So it's like a gradual step towards breathing on their own again.
Exactly. It encourages them to start using their own respiratory muscles again. Helps prepare them for weaning off the ventilator.
Oh, that's really interesting. Are there any other modes we should cover?
You bet. There's one more I want to highlight. CPAP. Continuous positive airway pressure.
CPAP, like I've heard of that before.
Maybe in the context of sleep apnea.
Yeah.
Think of it like a constant stream of air that keeps those airways open, particularly when you exhale.
Okay, so CPAP kind of acts like a splint for the airways.
Exactly. It prevents them from collapsing. In CPAP mode, the patient does all the work of breathing, but that continuous positive pressure makes it much easier.
Gotcha. This is all starting to click now. We've talked about why we need mechanical ventilation, the different types of respiratory failure, and now the different modes the ventilator can use. Sounds like choosing the right mode for each patient is pretty crucial.
It is. And don't forget about all those numbers and settings on the ventilator itself. They might seem intimidating, but those numbers are key for really tailoring the ventilation to each individual patient.
They control exactly how the ventilator does its job.
Precisely. And that's what we'll be diving into next. All right, let's break down those numbers and settings on the ventilator. They control how those breaths are delivered. One of the most important ones, tidal volume. It's often abbreviated as VT.
VT, okay. And what does tidal volume tell us?
It's the amount of air delivered to the lungs with each breath.
So if we set a tidal volume of, say, 500 milliliters, the ventilator pushes that amount of air into the lungs with every breath.
Exactly. And figuring out that right tidal volume is crucial. We don't want to overdo it and push too much air.
That makes sense. Wouldn't want to overinflate the lungs?
Right, that could cause damage. But we also need to make sure we're delivering enough to meet the patient's oxygen needs.
So it's about finding that balance.
Exactly. A delicate balance.
What other settings do we need to keep in mind?
Another key one is the respiratory rate, or RR. It determines how many breaths the ventilator delivers per minute.
Okay.
Again, balance is key. Too few breaths, you risk hypoventilation. Too many, and you could end up with hyperventilation.
Finding that right tempo for the patient's breathing.
Perfect analogy. And then there's FiO2. That stands for fraction of inspired oxygen.
FiO2, okay. Breaking it down.
It's basically the percentage of oxygen in the air that the ventilator is delivering.
Gotcha. So room air, that's about 21% oxygen, right?
You got it.
So if we bump up the FiO2 on the ventilator, we're giving the patient a higher concentration of oxygen.
Exactly. We tweak the FiO2 based on the patient's blood oxygen levels, aiming to keep them in a safe, healthy zone.
That makes sense.
And last but not least, there's PEEP, positive end expiratory pressure.
PEEP. That sounds familiar. Isn't that the same idea behind CPAP for sleep apnea?
That's right. PEEP is all about maintaining a little bit of pressure in the airways, even at the end of exhalation.
Ah,
It helps prevent those little air sacs from collapsing and improves gas exchange, especially important for patients with things like ARDS, acute respiratory distress syndrome.
so PEEP is like if you're picturing a balloon, it's keeping a little bit of air in there even after you've let some out.
Exactly. Keeps those air sacs open and working right.
This is fascinating. But how do we know which settings are the right fit for each patient? Seems like there's a lot to juggle.
Well, that's where a blend of clinical judgment and something called ventilator graphics come in.
Ventilator graphics.
Think of it like a visual representation of what's going on inside the lungs. You can see how the patient's responding to the ventilator.
Oh, cool. So it's like getting a glimpse under the hood, seeing how the engine is running.
Exactly.
Yeah,
Can you give us a rundown of what these ventilator graphics look like and what they tell us?
absolutely. One of the most common waveforms you'll see is the pressure versus time waveform. Pressure versus time. Okay.
It shows how the pressure in the airway changes over time during both inhalation and exhalation. It gives you a good idea of the patient's lung compliance.
Lung compliance.
Basically, how easily the lungs inflate.
I see. So if the pressure jumps up quickly during inhalation, that might mean the lungs are stiff, hard to inflate.
Right on. We call that decreased lung compliance.
Decreased lung compliance, right?
Could point to things like ARDS or pneumonia. On the flip side, if the pressure rises slowly and smoothly, that suggests good lung compliance. The lungs are inflating easily.
That's amazing. It's like the waveform is painting a picture of how well the lungs are doing their job. What other waveforms are there?
Another important one is the flow versus time waveform.
Flow versus time. Okay.
It shows you the speed and pattern of airflow in and out of the lungs. This one can help us spot problems like airway obstruction
Airway obstruction.
or air trapping, where air gets stuck in the lungs and can't be fully exhaled.
So if the waveform shows a slow exhale, that could be a sign of air trapping.
Exactly. We often see that with COPD, where those airways are narrowed and airflow is limited. Then there's the volume versus time waveform.
Okay, another one. Volume versus time.
This one shows the volume of air with each breath, how much is delivered and how much is exhaled.
So we can check if the patient's taking in and letting out the intended amount of air. And you mentioned something called the pressure volume loop earlier. What's special about that one?
The pressure volume loop, or PV loop. It's a really unique visual.
Okay.
It plots pressure against volume during a single breath cycle, like a fingerprint of the patient's lung mechanics.
Wow, a fingerprint. Okay, I'm intrigued. But how is this PV loop actually created?
Picture a graph. Pressure on one axis, volume on the other. As the ventilator delivers air, both the pressure and volume increase, so the loop moves up and to the right.
Okay, I'm visualizing it.
Then, during exhalation, both pressure and volume decrease. The loop moves down and to the left. Eventually, it circles back to where it started.
So it's like tracing the journey of a single breath. Shows how pressure and volume relate to each other throughout that breath.
Exactly. It's pretty neat.
It is. But how do we use all this information from the waveforms and the PV loop to actually manage the patient's ventilation?
Yeah.
Seems like a lot to process.
It's where the science and art of critical care really merge.
Okay.
We use our clinical judgment, we look at the data from the ventilator graphics, and we consider the patient's overall condition. That's how we fine-tune those ventilator settings.
It's like solving a puzzle, piecing together clues from different places to find the best ventilation strategy for each patient.
You got it.
Sounds like a challenge, but a rewarding one.
It is. Remember, the goal isn't just to deliver breaths, it's to deliver the right breaths in the right way, all to help the patient recover.
This has been so insightful. These waveforms and loops are like secret windows into what's happening in the lungs. Amazing. But what happens when a patient starts showing signs of improvement? When they might be ready to come off the ventilator?
That's a great question. It brings us to the weaning process. It's the gradual reduction of ventilator support, allowing the patient to take on more of the work of breathing.
Oh, okay. So it's like slowly taking off those training wheels.
Exactly. Weaning is all about empowering the patient to regain their ability to breathe on their own.
Makes sense.
Yeah.
So how do you figure out when a patient's ready to start weaning?
We look at a few things: their overall medical condition, their level of consciousness, their respiratory muscle strength,
Right.
and their blood gas values. Those tell us how well their lungs are oxygenating the blood and removing carbon dioxide.
So a holistic view of the patient's readiness to breathe on their own, physical and cognitive. Are there any specific tests or measurements that you use to help guide that process?
Absolutely. There's one called the Rapid Shallow Breathing Index, or RSBI.
RSBI.
It's a pretty simple calculation. We divide the patient's respiratory rate by their tidal volume. Lower RSBI usually means a better chance of successful weaning.
So if the RSBI is lower, that suggests the patient is taking deeper, less frequent breaths, a good sign for their ability to breathe independently. I'm curious about the different methods for weaning someone off a ventilator. What are some of the approaches?
Well, it depends on the individual patient and how they're handling the process. But one common method is SIV weaning.
SIMV, we talked about that earlier.
Exactly. We gradually reduce the number of breaths the ventilator delivers per minute. This lets the patient take more and more spontaneous breaths.
Gotcha. So you're shifting that workload from the machine back to the patient's own breathing muscles. What other weaning methods are out there?
There's also pressure support ventilation, or PSV.
Okay. PSV.
With PSV, we provide a little pressure boost with each breath. It makes breathing easier, but it still encourages them to use those respiratory muscles, like giving them a little nudge with each breath.
Ah, so it's a mix of support and challenge. Helps them gradually build up their strength.
You got it.
Are there any other techniques you use?
One more key step in the weaning process is something called a spontaneous breathing trial, or SBT.
SBT. Well,
During an SBT, we basically disconnect the patient from the ventilator for a short period, usually 30 to 120 minutes.
so it's a test run, seeing how they do breathing completely on their own.
Exactly. A test drive, you could say.
What if they don't do well during an SBT?
Well, if they struggle, we reconnect them to the ventilator and reassess. Maybe adjust their meds, provide additional respiratory therapy.
Makes sense.
Yeah.
It sounds like weaning is a really delicate process. Lots of monitoring and adjustments along the way. But what if a patient simply can't be weaned? What happens then?
It's a tough situation.
I imagine so.
Sometimes, no matter what we do, the patient's underlying condition makes it impossible for them to breathe on their own. We might have to consider long-term mechanical ventilation.
Long-term ventilation.
It's essentially ongoing life support for those who can't breathe independently. It comes with its own set of challenges and considerations, for sure.
Can you tell us more about how long-term ventilation works?
Absolutely. Long-term ventilation can look different depending on the patient and their situation. Some might use a tracheostomy tube.
Okay, what's that?
It's a surgical opening in the neck that connects the ventilator directly to the trachea. More comfortable for the long haul compared to a tube through the mouth or nose.
Gotcha. So it provides a more secure airway for the long term.
Exactly. And in other cases, we can use non-invasive ventilation,
Still an option for the long term.
especially for those who can breathe somewhat effectively on their own but need that extra help. Think of those with neuromuscular disorders or sleep apnea.
So even with long-term ventilation, we can prioritize those non-invasive options when possible. To improve comfort and quality of life, are there other key considerations for patients on long-term ventilation?
One of the biggest is ensuring they have the right equipment and support. That might include home ventilators, portable oxygen concentrators, regular visits from respiratory therapists.
Oh, okay.
Those therapists can monitor their breathing, make adjustments to settings as needed.
A whole team effort. What about the emotional and psychological toll on patients who need this level of support?
That's a crucial aspect. Living with a ventilator, especially long-term, can be a huge adjustment. Patients might feel all sorts of things: anxiety, fear, frustration, even depression.
I imagine they might feel like they've lost some independence.
Right. It's vital to create a strong support system for them. Counseling, support groups, resources that can help them adapt.
Helping them cope with this new reality.
Absolutely. Connecting them with others who are going through the same thing can be so powerful. They can share their experiences, find strength in each other.
It's like building a community of support around them, letting them know they're not alone. This has been an incredibly eye-opening conversation. But before we move on, you mentioned earlier that transporting a ventilated patient can be quite the challenge. Can you elaborate on the logistics and considerations involved in moving these patients safely?
Absolutely. Whether it's within the hospital for a scan or to a different facility altogether, moving a ventilated patient requires meticulous planning and a coordinated team effort. It's not as simple as it might seem.
What are the main challenges?
Well, one of the biggest is ensuring a continuous oxygen supply and keeping those ventilator settings stable throughout the transfer. We have to prevent any interruptions or malfunctions.
I can see how that would be crucial.
Right. We use specialized transport ventilators for this. They're portable, very reliable, and often have battery backups, plus built-in safety features to prevent any hiccups in ventilation.
Like a mini ICU on wheels, ready
Right.
for anything. What else do you need to keep in mind during transport?
We're constantly monitoring the patient's vital signs, breathing, and oxygen levels. For longer distances, or if the patient is in a more critical state, a physician or critical care nurse might even accompany them to manage any emergencies.
It sounds like a high-stakes operation, requiring a lot of expertise. And what about air transport? Are there additional challenges when moving a ventilated patient by airplane or helicopter?
Oh, definitely. Air transport brings a whole other set of complexities. One major factor is altitude. As the aircraft climbs, the barometric pressure drops, and this can affect how the ventilator delivers breaths, even impact the patient's oxygen
It's
levels.
like the mountain climber analogy we discussed before, but in reverse.
You got it. Less air pressure at higher altitudes means less oxygen available, which can be problematic for someone already relying on a ventilator. We have to carefully adjust those settings to make up for the pressure changes and ensure they're still getting enough ventilation and oxygen.
That makes sense.
And then there's the logistics of securing the equipment and ensuring it's compatible with the aircraft systems.
Wow, a lot to think about.
Mm.
Who's usually in charge of managing these complex patient transfers, especially when it involves air transport?
Often we have specialized teams called Critical Care Air Transport Teams, or CCAT-Ts for short.
CSATs, okay.
They're specifically trained to handle these intricate transfers. Think of them as the elite special forces of healthcare,
I like that.
equipped to handle just about anything that could come up during transport.
So what does their training involve? It must be pretty intense.
It's rigorous. They go through classroom learning, hands-on simulations, real-world experience.
Wow.
They need to be experts in airway management, critical care monitoring, emergency procedures, and they have to be amazing team players working under pressure in challenging environments.
So they're essentially saving lives in transit.
Exactly. Often they're the unsung heroes, working behind the scenes to make sure those critically ill patients get the specialized care they need, no matter where they are. They're the bridge between different healthcare facilities, ensuring that continuum of care for these vulnerable patients.
This has been such an enlightening conversation. I have a newfound appreciation for the complexities of mechanical ventilation
Yeah.
and the incredible dedication of everyone involved. The clinicians at the bedside, the transport teams, making sure patients get the care they need, even while on the move. It's remarkable.
It's been a pleasure sharing this with you. Hopefully it sparked a bit of awe and appreciation for the incredible advancements we've made in respiratory care and for the unwavering commitment of the people who have dedicated their lives to this field.
It certainly has for me. As we wrap up this deep dive into the world of mechanical ventilation, here's a final thought for our listeners. The next time you hear that rhythmic whoosh of a ventilator, remember, it's not just a machine. It's a beacon of hope, a lifeline for those fighting to breathe, and a testament to the power of human ingenuity, compassion, and collaboration in the face of life's toughest moments. Thanks for joining us on the Deep Dive.
It really is. It takes careful planning and coordination, not as straightforward as just moving a patient in a bed.
Right. I bet there's a lot more to it.
For sure, we've got to make sure the oxygen supply stays uninterrupted and those ventilator settings remain stable the whole time. Imagine if the ventilator acted up or ran out of oxygen in the middle of the move. That'd be a disaster.
That's a scary thought.
Absolutely. There's little room for error, so we take precautions.
So how do you minimize those risks?
We use special transport ventilators. They're built for portability and dependability. They've got battery backups, safety features, all to prevent interruptions, even if there's a power outage or some other unexpected glitch.
Oh, wow. So they're prepared for anything.
As much as possible. We're talking a mini ICU on wheels.
I like that analogy.
Right. And we can't forget about constantly monitoring the patient.
Of course.
Vital signs, breathing, oxygen levels. Got to keep an eye on all of that throughout the whole journey.
So much to watch.
Definitely. Depending on how far we're going and how critical the patient is, we might even have a doctor or critical care nurse on board, just in case there's an emergency.
That makes sense. You got to be prepared for anything. What about transporting by air? That's got to add another layer of complexity.
Oh, for sure. Air transport comes with its own set of hurdles. The big one is altitude. When the aircraft goes up, the barometric pressure changes. It drops, actually.
Oh, right. Thinner air, the higher you go.
Exactly. And that lower pressure, it can affect how the ventilator works and even mess with the patient's oxygen levels.
Reminds me of that mountain climber example we talked about earlier.
You got it. It's like that, but in reverse. Less air pressure means less oxygen available. And that's not good for someone who's already depending on a ventilator. We have to adjust those settings carefully to account for those pressure changes. Got to make sure they're getting enough oxygen and ventilation. Plus, there's all the logistics of securing the equipment and making sure it all works with the plane or helicopter systems.
Wow. Sounds like a logistical puzzle.
It can be.
So who's usually calling the shots during these tricky patient transfers, especially when it involves air travel?
Well, in lots of cases, there are special teams just for this. Critical care air transport teams, or CKPOTs.
The Pooties, got it.
They're the experts at handling these really complex moves. I like to think of them as the special forces of healthcare.
Uh-huh. I love that. Highly trained and ready for anything.
Exactly. What kind of training do they go through? Well, it's intense. They've got classroom learning, hands-on simulations.
Like boot camp for critical care.
Pretty much. They need to be proficient in everything. Advanced airway management, monitoring, emergency procedures. And they have to be incredible team players because they often work under a lot of pressure. And in tough environments, think the back of an ambulance or inside a helicopter.
Wow. Sounds like an incredibly demanding job, but also really rewarding. They're essentially saving lives in transit.
Exactly. They're often the unsung heroes. They're behind the scenes, making sure these really sick patients get the best possible care no matter where they are. They're the bridge between hospitals and facilities, making sure there's no break in that care for these patients.
That's incredible. This has been such an eye-opening conversation. I have a whole new level of respect for just how complex mechanical ventilation is and the dedication of everyone involved, from the clinicians working directly with patients to these specialized transport teams who are out there making sure patients get the care they need, even while they're being moved. It's remarkable work.
It has been a pleasure sharing all of this with you. Hopefully you've gained a new appreciation for the advancements we've made in taking care of people with respiratory issues and for all those people who've dedicated their lives to this field.
I definitely have. And to wrap up this incredible deep dive into the world of mechanical ventilation, here's a final thought for our listeners. Next time you hear that rhythmic whoosh of a ventilator, remember it's not just a machine. It's a powerful symbol of hope. It can be a lifeline for those struggling to breathe. And it represents the incredible ingenuity, compassion, and teamwork that come together when people face some of the toughest moments in life. Thanks for joining us on The Deep Dive.